Okay, students, so welcome back. Here we are in the course in bioethics, the master's in bioethics at St. Thomas University. So we're going to be shifting now from beginning of life issues to end of life issues in bioethics. But before we do that, always start with a little prayer. In the name of the Father, the Son, and the Holy Spirit. O Lord, fill the hearts of your faithful and enkindle in us the fire of your divine love. Amen. All right, so I was mentioning we're going to make this shift now from beginning of life to end of life issues. So we go from one controversy to another. And I can tell you there's a bit of chronology here. First of all, before I go any further, any questions or comments from anything preview? No? All right, so a few years back, I would say maybe 15, 20 years ago, most of the issues were still beginning of life issues. But now, little by little, the end of life issues have been creeping in or becoming more relevant. And again, part of it is technology that people can now be maintained. Excuse me. Thank you. Can we maintain alive longer than before? So technology has an impact. And again, it's the whole thing of it can be done, right? But should it be done? So it can be done, but should it be done? And that's why we're getting an increasing number of questions and consultations on end-of-life issues, especially since people can now be maintained almost indefinitely, or their bodies anyway, organic function, and with a ventilator and so forth. But it's a question of whether the mind is really there or not, all right? So we're going to set up the stage, if you will, this lecture, but then next lecture, we'll get into the actual definition of death, which is going to be both a legal definition and a clinical definition of death, because at some point, everyone needs to be declared dead before being buried, all right? And it's not without its controversy. All right, so today we're going to be looking first just kind of the introduction to end-of-life issues. One way or another, it has to do with vital organs, okay? And whether we are assisting or substituting vital organs, and that's going to be a key question. So another thing that is different that makes it a little more difficult at times to determine what to do, whether to keep the person connected or not, is because in contrast with beginning of life issues, when we begin as one cell, right? And that one cell, the zygote, is either dead or alive, so we can determine quite certainly when the beginning of life happens, and again, not only with our species, but across the board for any species. At the end of life, evidently, we have trillions of cells, and they don't all die at the same time. In fact, they will die at different rates depending on the organ system. So it's actually the scenario that some organs are dying or dead, and some other organs may still be alive. And if we get down to the tissue level, it's even more so. And it has to do with this issue of the fact that we have trillions of cells, the vast majority of which are already fully differentiated into organ systems, right? But they certainly don't all die at the same time. So we can talk about the process of death, all right? And even so, there has to be an actual moment before which we are alive and after which we are dead. All right, so I want to look at vital organs, and then just statistically in the United States, some major causes of death. And finally, the distinction between assisting and substituting vital organs. That's in the first half of the lecture. And in the second half, we're going to see different states of unconsciousness, because It has to do again with the issue of especially the brain, right? The mind and the brain. So moving forward, just a very quick review of life, organic life, as we know it here on Earth. We know that the basic unit of life is the cell, right? If the cell is metabolizing, we can say that that cell is alive. But typically, cells are not living on their own unless it's a protozoan, a unicellular organism, and there's a whole grab bag of that category. But when we come to humans, of course, we're multicellular, and there's a hierarchy of differentiated cells. As cells become differentiated, they form tissues, and in general, it has to do with function, right? Cells with similar functions, they form tissues. Tissues with similar functions, they will form organs. Organs with similar functions will form systems, or what we call organ systems. And then finally, when we get to the organ system, then it shifts, because we have different organ systems, anywhere between half a dozen to a dozen, depending on how they're classified. The classification varies a little if we're focusing functionally or structurally, all right? So what is an organ system of the body? Anyone? Digestive system. Those would be the organs that make up that system, right? So digestive system, what's another one? Anybody? Endocrine system, respiratory, okay. Nervous system, skeletal system, muscular system, but we're focusing mostly on the structures themselves. If we look at it functionally, you will run across the skeletal muscular system as a single one. And that's looking at it functionally, because obviously the etiology of those cells or those tissues is different, right? And yet they function together. Specifically, that would be skeletal muscle, right? Different from the smooth muscle, which is unattached generally. And so it depends whether we're looking at it structurally or functionally. That's why I say anywhere between half a dozen to a full dozen of organ systems. Either way, when we get to the level of the organ system, then systems that have different functions coming together form the whole organism. So there's a complementarity at the level of systems, right? Systems with different functions, they form organisms. So up until the system, it's been similar functions. Cells with similar functions form tissues, tissues with similar functions form organs, organs with similar functions form systems. You follow? And then the systems themselves are complementary to each other, and then all together, put together, then they form the organism. So just to be clear on this hierarchy, this will help when we need to define death, and is this patient dying, right? Okay, is this patient dying or not? And what is the system that coordinates all the other organ systems for the human? Generally, and this is true in general, it is the nervous system, right? The nervous system. In fact, there's a central nervous system, there's a peripheral nervous system, so that we have voluntary action on which system of the nervous system, which one of the two? The central nervous system, which includes the brain and the spinal cord and all the innervation to what muscles? To the skeletal muscles, which is the one that moves the skeleton. And so we're able to move our skeleton through all that system voluntarily. There's another system of muscles, like I mentioned, the smooth muscle, right? And they are innerved by the peripheral nervous system, over which we don't have volition normally, all right? And so they do their own thing, and typically those are innerved to the cerebellum, not the cerebellum, the brain stem, okay, the brain stem. And so that runs the smooth muscle, and also it runs the heartbeat, which is the third type of muscle, right? The cardiac muscle. For that one, we only have one type of that third type of muscle, the cardiac muscle, which has a double characteristic. Of course, it's unnerved by the involuntary nervous system hooked up to the brain stem, but also that muscle itself is different from smooth and skeletal in what other characteristic? The cardiac muscle has also a self-beat, has a self-pulsing. And that happens, I don't know if you ever watched those little videos that I had there, but you'll see when the heart starts forming, the cardiac cells are beating on their own first, and as they cluster together to form the cardiac tissue, right, which will then become the cardiac muscle, as they come together and they hook up, they start coordinating their pulsation, and they will start pulsing in sync, which will eventually become the heartbeat. And that's the 150 to 200 heartbeats that I mentioned per minute on the human embryo and the human fetus, because it's a lot of very fast circulation, right? Even though the little embryo is tiny, yet that blood system needs to move very fast because there's a lot of metabolism going on in that spurt of growth during the first 9 months. Anyway, so this is a hierarchy of systems, and we're going to be focusing at this level, at the level of organs. All right. So let's think about vital organs, because we have many organs in the body, and a number of them are important, but not necessarily vital organs. Who can tell me an organ that's important, certainly, but not vital? In other words, we can live without it. The appendix, yeah. But the appendix, how important is the appendix?
It's important, but we can live without it.
So, well, so it has developed kind of a secondary function, right? Associated with what? Anybody know the appendix?
It has like those microbial communities.
Does it? Okay, it may have that, but I was thinking more is being associated with the immune system somehow as a secondary function. But originally, it used to be like another pocket of the digestive system, right? For the ruminants.
That's the microbes, actually.
Okay, so in other, like in ruminants, in mammals that eat grass, like cattle and so forth, right? They chew the cud, and then that cud has to be digested in those extra chambers of the stomach, because cellulose is very hard to break down, and we don't have cellulase, but bacteria do, or microbes, microorganisms. I was thinking of the eyes, for example. The eyes are very, very important, you know, but
Also like organs that you get in pairs, you can use one.
that too, but still typically they are vital, but you can lose one or donate one or have one excise. Yeah, exactly. But I just trying to say that, for example, the eyes, there are a number of organs that are very, very important, but they're not vital in the sense that they don't keep us alive. Interestingly, even the reproductive system as a whole, this is a whole system, you know? A system is even beyond the organs, it's at the level of whole system. The reproductive system, as important as it is not really vital because individuals can live without that reproductive system. Of course, it's vital for the next generation. But at that point, it's at the level of the population as a whole. As long as some individuals of the population are reproducing or procreating, then that's enough, right? But at the individual level, as important as the reproductive system is, it's not really vital in this sense for the individual, all right? But certainly vital organs are necessary for life by definition. So that's what I want to focus on since we're looking at end-of-life issues. You'll see my point in a minute. Here is just a brief diagram of the organs starting from the head down. Is mostly the head and the trunk, right? So we have the brain and the brain stem, also known as the medulla oblongata. So the brain and the brain stem. Then both lungs, you notice I'm putting it functionally because like Luis mentioned, for paired organs, we can do without one of the pairs and still keep on living, all right? That's true very especially of the kidneys. We actually have 5 lungs or 5 lobes. There are 3 on one side and 2 on the other side. And the minimal that is needed is, I believe, 2 lobes. And of course, that person is not going to run the marathon, right? They can live a very sedentary life, but they can be alive with just 2 lobes. That is significant when we come to talk about transplants and living and cadaveric organ transplants. The heart, which is single, of course, the liver actually has how many lobes? 3 lobes, all right? The liver has a lot of regeneration power. You can cut out basically 1 lobe of the liver and it will regenerate.
Here's a deal for every moment on the McDonald's $1 order.
Derek, mute your mic, please. Thank you. Thank you. Okay. So the liver has regeneration power that has stem cells basically. And so we can cut out a section of the liver and it will grow back, maybe not to full, but pretty much. That's a good thing also because what's one of the main functions of the liver? To filter.
Filtration.
Filtration, exactly. And for example, medication, right? So filter toxins and medication, which for the body, medication may be considered toxins. Alcohol, for example, also. And so the liver takes a real bang, if we will. That tissue takes a lot of beating and therefore has to be regenerated periodically by the body itself. Then going down to the digestive system, stomach, intestines, small intestine and large intestine. I hope you're again clear on the fact that why they call small and large is a reference to what? To their length? No, because which is longer of the small and the large? The small intestine, by a large amount, right? It's about how many feet of plumbing do we have in there? About 20, 24 feet? Yeah, it's about 20, more than 20 feet of small intestine, right? And whereas the large is about maybe, what, 5 or 6 feet, I think it is. Anyway, it's a question of diameter. It's the diameter. So small intestine is a very smaller gauge, if you will, compared to the large intestine. And you can see it here graphically. But the length itself, the small intestine by far is much longer than the large one. Anyway, as a whole, because people can do without a section of the stomach, without a section of the intestines and so forth. So we take the stomach and intestines as a whole for vital organ. The pancreas is probably one of the smallest vital organs, but it is vital. What does the pancreas do? It's a big gland, actually produces insulin, which regulates glucose or the blood sugar, right? So diabetes has to do with the pancreas, all right? And it regulates blood sugar. If it's too much sugar, it's a problem. If it's too little sugar, it's a different problem, right? So the spleen, as small as, I'm sorry, the pancreas, as small as it is a vital organ. The spleen, frankly, I don't know, but I don't think the spleen is so there's a such thing as a splenectomy, right? I think the spleen is not a vital organ. What does the spleen do? No? RBCs. It breaks down old RBCs because red blood cells get worn out very fast. First of all, mature red blood cells, do they have a nucleus? Kind of begging the question. They don't have a nucleus, mature red blood cells, all right? They enucleate, I guess, to have more space for the hemoglobin. At any rate, without nucleus, then they cannot regenerate and they become old fast. And the spleen digests old RBCs, breaks them down. All right, and what makes the RBCs? Bone marrow, all right? Especially the ribs, the femur, inside. So how do those blood cells get out? It makes red blood cells, white blood cells, platelets, okay? How do those cells get out of the bone? If it's the marrow, it's in the inside of the bone. Exactly, it's porous. At the macroscopic level, if we were to look at a bone, even a dense bone, it would look very smooth, right? At the microscopic level, it's certainly porous. So the cells go right through the bone, literally, and then the bone is all vascularized at full of capillaries on the periphery, picking up those blood cells, okay? And speaking of blood, The blood is also an organ by itself, and it's considered the only liquid organ. And why is it an organ? So an organ is made up of tissues that have similar function, right?
So it has a large complex of cells in it.
Yeah.
That in many cases they cooperate to achieve some kind of results.
Yeah.
Like with clotting or whatever.
Exactly. So I'm not thinking of the actual capillaries and such. The arteries and veins are actually made up of what? What? Arteries and veins themselves, what are they? They're, yeah, well, it has a lot of collagen. It's elastic, but it's smooth muscle, basically. It's smooth muscle, all right? But the blood itself within is considered an organ. Why? Because it has tissues that does similar functions. Minimally, 3 main tissues in the blood, right? We have the red blood cells. They're cells with similar functions. So the whole of the RBCs in our body can be considered a tissue, which is gas transport. Then the white blood cells, which are of different types, right? The T cells, the killer cells, the phagocytes, et cetera, macrophages. And those white blood cells clustered form the tissue of the WBCs. And so that's another tissue of the blood. And then the third one is, for clotting precisely, platelets, the platelets. All right, so that's what the platelets do for clotting. And that's why hemophilics have difficulty. Their platelets are not functioning correctly. They need some factors involved in the process. So that's why there are at least three tissue components of the blood, which are RBCs, WBCs, and platelets. And therefore, blood as a whole is an organ. It's the only liquid organ in the body. And then the liquid fraction is what? The serum. The serum is kind of amber color, has a lot of nutrients in it, right? Lymphatic system, by the way, speaking of the nutrients, it's another system. Okay, the kidneys also paired. And so both kidneys functionally are also vital organs. Since we're looking at issues at end of life then, so the point here is that we can say, trying to arrive at the issue of, is this person dying, right? Is death imminent, or is the death process have begun? Sometimes the death process is subtle, but real. We can ask the question, is any one vital organ dying irreversibly? You know, imminently dying, then we can say that the death process has begun, but it may be subtle because the person may still be conscious, talking, moving, and so forth, but maybe they're on renal failure, okay? And it's a matter of time before that kidney finally shuts down and the person literally becomes intoxicated from their own waste, metabolic waste. So we can say that when there is irreversible renal failure, the death process has begun, you see? And sometimes it's dramatic, like maybe a blow to the head or something like that, or cardiac arrest, or sometimes it may be subtle, but real. So just again to review, in the US, causes of death, here's a list of the first 15 causes of death, which account for about 85% of all deaths in the US, this first 15, all right? Whereas the first 5 account for about 2/3. I just added this up a little bit. So the first 5 causes of death account for 2/3 of deaths in the United States. And the first 2 account for 50% of all deaths in the United States, which are basically heart attack or some heart failure and various types of cancer. Of course, this is, again, a grab bag because there are many different types of cancer, essentially uncontrolled growth of cells. But if that happens on vital organs, then sooner or later, that organ is going to fail. right? So these are two major causes of death in the United States. And then a third one that is not a very close third, but a distant third from the averages, from the percentage, is essentially stroke or some other disease of the brain. Okay. Then I have listed here the primary organ, the primary vital organ that is affected. Of course, for cardiac failure, the heart. For tumors, it could be any vital organ. For strokes, it's going to be the brain. And then for lung failure, respiratory failures, lungs, etc. Diabetes, going to be the pancreas. Further down, the kidneys, finally. That accounts only for less than 2% of deaths in the US. Even so, I can tell you a little bit more about kidneys, that right now, this is one of the most common failures of vital organs, kidney failure. Right now, there is on the kidney transplant list waiting for a kidney, right? People on kidney failure is about 100,000 in the United States alone. It's the largest waiting list for organs, for vital organ transplantation, not only in the United States, but throughout the world, is kidneys. Ironically, we can actually donate a kidney and keep on living a normal lifestyle, okay, as long as we're healthy enough to be a kidney donor. And so that list of 100,000 could be wiped away if a small percentage of the population gave one kidney. Talk more about that later when we get into, we'll have a whole class devoted to transplantations, living and cadaveric transplantation. But of course, there are other organs that are also transplanted that are not vital, for example, the cornea and so forth, all right? But the most controversial issues, at least bioethically, is with vital organ transplantation. And that's why it's important to be very clear on the declaration of death. Or cadaveric organs, we don't want to be removing vital organs on a person who's still living, right? Because then that's going to kill it. All right, so this is just a review of vital organs and how they play a role in the life and health of the American population. Different countries will have different statistics. It's also kind of ironic that the first two, which account for 50% of the deaths in the US, many times are related to stress. And in other countries, these numbers, these stats will vary quite a bit, right? And for example, if you're going to developing countries, stroke and heart attack are not major causes of death. But yet here in the US they are, and in more developed or industrialized nations. And so that speaks of what? This common background factor that we have in our lives as we grow and grow, stress, right? The pressure, we need it now, or we need it yesterday, that kind of thing. And so that stress is taking its toll on the population, particularly. And also, you know that tumors have some association, at least indirect, with stress, in that stress can lower the immune system. And when we lower the immune system, it can also expose us to, we're more susceptible to tumors and to infections. So stress is something that we need to manage well, otherwise it will manage us.
I was going to say, great, everything stressed about.
Yeah, right, stress about stress. That's right, yeah. Okay, all right. So now I want to jump quickly into the bioethical side. So it's a little bit of the biological / clinical, because again, bioethics, right? Now, the ethical analysis, one of the main principles that we use at the end of life is the distinction between assisting or substituting vital organs. The distinction between assisting or substituting vital organs. Because again, we used this a little bit when we were looking at IVF, in vitro fertilization versus artificial insemination, for example, right? Or NFP, that IVF substitutes the literal place of fertilization. So it's done in the lab as opposed to in the body where it's supposed to take place. So similar, this principle is also applicable with end-of-life issues with regards to vital organs, because we find bioethically a distinction between assisting or substituting vital organs. And the basic principle is this. Is there generally an ethical obligation to assist vital organs? How many say yes? How many say no? Is there an ethical imperative, an ethical need to assist vital organs, to assist them? Yes, there is, okay? But how about substituting vital organs? Our intuitions should tell us that there is no obligation, there's no ethical obligation to substitute vital organs. That might sound a little hard, especially for people who are considering medicine, right? Because you would think, well, if there's a cure, yeah, but what if there's no cure? Okay, what do we do? Medicine has its limits also. At any rate, if you think about it a little bit philosophically, imagine when a principle is not too clear and sounds a little hard, flip it around, okay? Do the opposite, right? And see if it makes sense. Imagine that there was an obligation to substitute vital organs when they're failing irreversibly. How are we gonna do that? You know, sooner or later, every heart's gonna fail, every brain is gonna fail, every kidney, every lung is gonna fail, and how are we gonna substitute them? Not even artificially. If at some point we were able to develop the ideal heart machine and so on and so forth with all the vital organs, then we could possibly make a claim, you know, that we should substitute vital organs, perhaps depending on the age of the person, whatnot. But there's no possible way that we could substitute clinically every vital organ that is failing. Okay, it's untenable. And so no, there is no obligation to substitute vital organs once they are failing irreversibly. All right. Individual people may want to do so, may seek to do so. So for example, transplants, there's no obligation to have a transplant, but people may decide to do so. And typically that's known as heroic means, right? Heroic means, but it doesn't, at least it doesn't obligate ethically to do that. I'm going to give you some examples because here we're going to run into some conflict between the bioethical language that we're using and the clinical language that is used by the medical profession. All right. Here's an example. I'm going to give you 3 examples, one with kidneys, one with heart, and the other one with lungs. So 3 sets of vital organs, right? So let's look at the kidneys. Vital organs, a person going on renal failure, what is indicated? Typically, what would be the prognosis or what would be the protocol for a person on renal failure? Dialysis. Dialysis. So here's a dialysis machine, here's a dialysis center, all right? And these are the technicians checking on the settings, because what does dialysis do? Functionally, you can see a person is hooked up. They will take out the blood and put the whole blood system through the machine and then pump it back in. And as the blood goes through the machine, it actually filters the blood. All right, it filters the blood for toxins. And that's down to the biochemical level. So these are very, very sophisticated filters. And also, the machine works by similar to the kidneys in that, you know, we don't secrete the toxins in a solid form or crystals, but rather it's diluted in our urine, and that's why the urine is yellow, because it has mostly nitrogen, which nitrogen is yellow. It's a natural state. So the machine, the dialysis machine, works the same way. It also uses water. What I'm trying to say is that it takes out some of the water from the blood of the patient. So that water needs to be replaced. And what happens when we play around with the water in our blood? What increases or decreases? If we increase or decrease the amount of water that we have in the blood, we increase or decrease what? The blood pressure. Yes, more water, less water, all right? And so the kidneys are also what is known as osmoregulators. They regulate the blood pressure. And that's why patients going on dialysis, they have to sign a form because they can go into cardiac arrest. And that's why these machines are monitored all the time, and they have all kinds of bells and whistles associated with them in case the margin goes out of range, then alarms will sound and so forth, and there are nephrologists and sometimes cardiologists on call in case, God forbid, one of these patients goes on cardiac arrest because of a disbalance of the machine, all right, malfunctioning. So these machines are calibrated and so forth on a regular basis, but they're pretty sophisticated is what I'm trying to say. And look at the size. Again, these may be a little older. They've probably gotten smaller nowadays, but basically this machine to replace one kidney. So you can see how efficient the kidney is. You know, nature has it down to optimal, much smaller, and does the same function basically. Okay. Anyway, what I'm trying to say by all this is that the kidney, the dialysis machine, is this assisting the kidneys, or is it substituting the kidneys?
Well, you said it's replacing one, so it won't be assisting.
Well, think again. Let me give you a hint. The patient could be on irreversible kidney failure, renal failure, all right? Total renal failure, the kidneys are non-functional. And so the dialysis machine can actually substitute the kidneys. And that's where I wanted to take it, that even though, so dialysis is pretty much standard medical practice. Person on renal failure, go on dialysis, that's the protocol. So as far as the clinician is concerned, that is standard medical practice. That's standard of care for a person on renal failure, all right? But bioethically, dialysis could be considered extraordinary means of life support. It is substituting the kidneys. And therefore, there's really no obligation for these people to go on dialysis. Or at some point, they can say no more, because this is what happens also. So this would be, a number of these people would be on the list for a transplant. They may be waiting for several years. I have a friend who needed a new heart. His heart was down to about 4%. Him and the wife, they have a little townhouse down in Homestead. Before the transplant, it would take him the whole morning to come down the steps and the whole afternoon to go back up. So he would only do that trip once a day because it was very debilitating. He only had about 4% of the heart working. Very, very sedentary life. He waited 10 years for a heart, and he finally got a heart transplant. It was amazing. It's been about 3 years now. That was done at Jackson Memorial Hospital here in Miami. But we're about the same age, more or less. And he got his heart transplant. And the first thing he did, I went to visit him one time, and he had already recovered quite a bit from the surgery. It's open heart surgery, obviously, and all that. He was back home and already was feeling pretty good. The first thing he did a few steps of cumbia Colombia. He's Colombian, and that's a very fast beat. If he had done that 10 years prior, he would have been dead on the floor. So it's pretty amazing. He got the heart of like a 19 or 20-year-old. It's incredible. So these transplants really work. So many of these people in a dialysis center, right? are waiting for a kidney. And they can be on the list years and years and years waiting. However, the dialysis machine itself is debilitating in the long run. It's more and more debilitating. So some people at some point decide, if they're low on the waiting list and so forth, they decide they don't want it anymore, okay? And they can opt out. And so they would be just basically allowed to die in peace, but there's no obligation to go on dialysis. But you tell that to a doctor and they're gonna say, what are you talking about? This is ridiculous because, you know, dialysis is standard medical practice. So again, you would have to sign all kinds of forms and release, so that you're relieving the doctors of any responsibility for not wanting dialysis. It's a very clear case where dialysis substitutes the kidneys, not just replaced, not just assist them. Okay, let's look at the lungs. And in the lungs, we have two cases. We have respirators or we have ventilators. Now, respirators typically assist the lungs, but the lungs are doing the breathing on their own. Whereas the ventilator, depending on the setting, may assist or substitute, all right? So let's take a look for a moment. First, here are some examples of respirators or cannulas. As this one is the simplest type. It's just providing, what is providing here? Oxygen, just pure oxygen, right? That's why it's not good to, not allowed to smoke in hospital rooms, because they have these little cannulas from the wall and it's just pure oxygen that is coming out. And so it's assisting the lungs, but the lungs are doing the breathing on their own. They're just being assisted with pure oxygen. So that's the simplest one. Then there's also this loose mask, right? It's a loose mask, but it covers nose and mouth, but still the lungs are still breathing on their own. All right, so respiration is still going on. It's just receiving a larger amount of oxygen this way. The third one is a mask that is also includes mouth and nose, but it's a tight fit. It's a tight fit and you can see the straps around it and so forth. So this is a more drastic way of supplying oxygen through the mask. This one is called a CPAP, right? They call it CPAP. At any rate, this provides, again, pure oxygen in a more direct way because it's sealed around, but the lungs are still doing the breathing, right? Inhaling and exhaling. And therefore, all of these respirators are assisting breathing, assisting the lungs, but not substituting. Different is going to be the ventilator, which is a machine that has all kinds of settings on it and then has a tube, and that tube will be inserted through the mouth, through the throat, down into the lungs. And so now this tube will actually assist or substitute the lungs depending on the setting, all right? And what happens here is that there's a bellows down here. It's kind of like a piston that goes up and down and is forcing oxygen directly into the lungs. And in that forceful positive pressure, it's actually expanding the lungs and then it will relax so that the lungs can contract and expel the CO2 and so forth. So the machine also on the backside will take the CO2 and discard it. So you notice that the machine here, the respirator, is actually substituting the lungs by way of the positive pressure, the positive air pressure or oxygen pressure being pumped into the lungs, okay? And the typical scenario is that this kind of ventilator can stay 2 to 3 weeks, 3 maximum, but after that, it has to be extracted, and then if the patient has not recovered by then they have to do a tracheotomy and go in through a hole at the base of the throat, bypassing the larynx, because what happens after a couple of weeks, the vocal cords and all that get irritated, and it can cause also infections, and the infections can go down to the lungs, which would cause pneumonia. And therefore, this tube, the first type of intubation that goes right through the throat, through the vocal cords down into the lungs, can only be held 2-3 weeks maximum. So it's a very dynamic system. Actually, as soon as a person is intubated, the protocol calls for what is known as weaning. They try to wean, right, the patient off the machine. So at first, let's say a patient comes in, maybe he's unconscious, they don't know what happened exactly, but he's not breathing or not breathing well. Could have been a drowned victim or someone like that. They intubate the person and they set the settings at 100%. So it's pumping oxygen 100%. And then they test. They lower the machine a little bit and see if the lungs begin to respond. All right. If the lungs respond, they will continue to lower the setting on the machine, the pressure, so that it's a lesser percentage. And if the lungs continue to pick up the slack, then they continue to lower the settings on the vent, and that's called a weaning process, right? So it's a very active dynamic, because also what happens, the lungs, like any other tissue, get lazy. And if the lungs are receiving the oxygen without doing any effort, they get used to that, all right? And so the lungs can get used to being provided 100% oxygen with positive pressure, and they get lazy and don't want to do the work anymore, right? So again, after 2 to 3 weeks, if the patient has not recovered, say from pneumonia or whatever the issue is, then they have to extubate. And if once they extubate, depending on where he's at the setting, let's say that the patient is down to 60, 50% on the setting of the ventilator, and they extubate, the lungs will start picking up on their own, and the patient has recovered. But if the patient has not recovered, then they have to re-intubate, and they would have to do then a tracheotomy, which is a hole in the trachea at the bottom, at the base, and then put the tube in through there, okay, all the way down into the lungs. So the hole itself is called a tracheotomy. The actual hole, the opening, is the tracheostomy, all right, and the operation is a tracheotomy. People can live with a tracheostomy, in other words, with a hole at the base of their throat. Typically, they have lost the ability to speak with the vocal cords, all right? But there's a little apparatus now that can be used, and they can put that apparatus next to the throat here, and with different movement of the throat, they can actually vocalize sounds. Also, that hole needs to be protected, obviously, because it's a direct passage into the lungs. So they will wear a scarf or something like that to protect the opening into the lungs. So the vent is another example where it could be assisting or substituting the lungs, depending on the settings. Typically at first it is substituting, but then if a person is recovering, then at some point it will start assisting, and then if they extubate and the person continues breathing, then the person has healed, all right? Otherwise, they may have to do that trach. And once they do a trach, the patient can be maintained in a vent essentially indefinitely until other vital organs give way. Because at this point, the lungs are being substituted totally. They're getting 100% oxygen, and it's just a question of the passive exchange of gases at the level of the alveoli. If the patient has no other comorbidity or any other illness going on, especially with vital organs, some people can last for years and years in bed a trach, with a vent, but they will be, of course, what we call vegetative state, or it could be an induced coma. Sometimes they induce a coma on the individual so that the individual doesn't move around, because it's very uncomfortable to have a tube through the mouth, right? And typically what do people want to do? They want to pull out the tube, which is not a good thing to do on your own. And therefore they induce a coma on the person, which will have a sedative and a muscle relaxant at the same time. Yeah, the typical protocol for this would be like pneumonia, where the person is taking antibiotics, is receiving antibiotics, IV, and needs to recover. The lungs need 1 to 2 weeks for the antibiotics to kill the infection. Third case, the heart, again, vital organ. So CPR, cardiopulmonary resuscitation. It makes a difference whether we're going to do CPR on a 20, 30-year-old, or we're going to do a CPR on an 80 or 90-year-old. What's the problem with the elderly? It has to do with the bones, the fragility of the bones. What happens as we age, we lose calcium, right? Women more than men, and therefore the bones become more brittle. And the compressions on the heart for CPR are pretty strong. And so for an elderly person, those compressions may actually end up what? Breaking the ribs. And sometimes when the ribs break, they can also perforate the lung. And now you got a double whammy. You have a person who's having heart problems, but in trying to fix that or trying to resuscitate the heart, then you end up with a patient with broken ribs and perforated lungs, which is a bigger complication, all right? So it could be that for elderly, CPR is not indicated, depending on how frail they are. All right. For the young person, because it's a premature, death. Oh, I forgot to mention the average lifespan in the US is around 80 years old. Well, we're gonna cover that with brain dead. About 78 for men and 81 for women. But basically, that's just to be used as a guidepost. So we can say that in principle, any death prior to that is a premature death, right? So if that can be avoided, that's a good thing. That's why it will make a difference whether we're doing CPR on a young person or in an elderly person. But basically, the CPR, the cardiopulmonary resuscitation, is it assisting or substituting the heart? Well, again, depends. If it's a full-blown heart attack, then that heart is stopped, right? That heart has stopped, and therefore, that's a vital organ that has stopped functioning. So really, CPR generally substitutes the heart to get it started up again, not just assisting, but it really is substituting the heart. And yet, here's another example where the bioethics may be a little bit in discrepancy with the clinical practice, because CPR in general is done unless there is some reason for not doing it. But the default is to do CPR on someone who has cardiac arrest. So again, it's a judgment call. It's very challenging. Typically the paramedics or first responders, who are people who are professionally trained in doing CPR, right? They know and they make these distinctions. I think they're also protected by law so that they're not suable for reviving someone and in the process breaking their ribs or perforating their lungs. And finally, the last example is with defibrillators, which is a little different. It's not actually a heart attack, a full-blown cardiac arrest, but it is when the heart has a, it starts undulating, has arrhythmia, loses the rhythmic pattern of the heartbeat, okay? So these defibrillators is one, there's one of these machines right across the hallway there. I don't know who's ever gonna use that, who would dare to use that machine, but basically it sends an electrical current through the heart to reestablish the rhythmic pattern of the heart. Okay? There are different types of defibrillators listed here, but this can also be considered assisting or substituting. It's going to depend a lot on the particular condition of that patient. So the bottom line about all this, beyond the vital organs, is that the distinction, the critical bioethical distinction between assisting or substituting vital organs and the fact that there is generally an obligation to assist the vital organs, but there is no obligation to substitute them. One may do that if one wants, and like I mentioned, they're called heroic means, but it doesn't obligate bioethically. Okay, any questions on this? Nothing? We're gonna move on to the second part then, unless you want a little break or something. It's almost 3:10. Well, we got about 20 minutes to go. Keep going? Yeah, good, thank you. All right, so let's look at the unconscious state, because this is one of those cases, particularly the most important one that concerned here is the vegetative state, persistent vegetative state, or permanent vegetative state, otherwise known as PVS. But before we get there, we have to go through a couple of others or several different types of unconsciousness. First, we need to define what is consciousness. So awareness of self and the environment is a functional definition of being conscious. Awareness of self and the environment, right? Now, the environment can also be internal or external environment. External environment is what we're receiving through the 5 senses. That's why they're known as the external senses. And the internal environment is just a general awareness that we're metabolizing, that we're breathing and so forth, that our heart is beating, we have circulation. But sometimes the senses are not working at 100%, and so we may have a difficulty of determining if a person is fully conscious or not. The converse of that, an unconscious state, is any lack of response to painful stimulus is considered that the person is unconscious, all right? A lack of response to painful stimulus, because a normal person who is conscious will respond to a painful stimulus, all right? A pricking from a pin or something like that, or a pinch, whatever. So there are different types of unconscious states. Just listed here are a few: coma, persistent vegetative state, traumatic head injury, brain hypoxia, lack of oxygen, epileptic seizures, syncope, which is a fancy name for fainting, and then other unconscious states that we'll look at briefly, especially locked-in syndrome. So starting with coma then, there is actually a scale to see whether a person is in coma or not. And this was developed back quite a few years ago. And it's known as the Glasgow Coma Scale. It looks at 3 stimuli and responses, which is verbal, eye, and motor. Okay, muscle movement, verbal response, and then eye response. And the score is from 3 to 15. It's 3, the minimum is 3 because each one of these 3 has a minimum of 1. And when you add those 3 ones, you get the 3, all right? So the minimum is not 0. The minimum is 3. And the maximum is, the score varies a little bit. For the eye, the maximum is 4. For verbal, it's 5. And for motor is 6. When you add 4, 5, and 6, you get 15. So the range of the Glasgow Coma Scale is from 3 to 15. That's the range. The middle of that is between 7 and 8, right? So above 8, the person is considered conscious. Below 7, the person is considered unconscious or in coma. And that's how it's established. So let's look briefly at the categories. The reason why they have each one of the 3 categories or behaviors have a different point system is because there are more things or less or fewer things that they're looking at. So for the eye, for example, if there's spontaneous movement, the eyes can move spontaneously, then that's considered 4. If the eyes are kind of blanked out and they only respond to speech, when someone talks to me, I'll look at them, that's a 3. If the eye only responds to pain, but not to speech, then that's a 2. And if there's no response, it's a 1. You follow how the scale works, right? Similar argument for verbal, but then they test for 5 things, so it's 1 through 5. And then in motor, again, something similar, but they test for 6 different behaviors or responses. So adding all that, like I say, would be 15. And it could be that the person is high on one, but low on the other. So it's really a composite, all right? It's a composite. And that's why they take the mid-range, the average, or the midpoint, which is 8. Above that, the person is not in coma. Below, the person is declared in coma, which is important to get a diagnosis. Remember, there's no prognosis without a diagnosis. So what the clinicians are trying to do is give a diagnosis. This person has come into the emergency room, the ER, and the person is unconscious or semi-conscious. We don't know. So to declare him in a coma or not, right? Different from persistent vegetative state, which sometimes is known as permanent vegetative state, all right, or PVS, or sometimes you just see VS, vegetative state, as in here, to abbreviate it even further. Here are some, these are 3 MRIs done on different individuals, just for comparison. We know they're different individuals because you can see that the face is different. All right, the anatomy of the face is different. But just for comparison, the person who is fully conscious, you see there's a lot of activity going on in the brain, illustrated by the colorized image here. This, by the way, is a magnetic resonance imaging, MRI, right? And the MRI, is it invasive or non-invasive? Non-invasive is magnetic waves essentially going through, it's a pulse of magnetic waves going through the skull, and it is able to image soft tissue, which X-rays cannot do that, right? X-rays are hard tissue, number 1. Number 2, X-rays can cause mutations, whereas magnetic resonance does not cause mutation as far as we know. And we're exposed to magnetic resonance all the time. What's the biggest magnet on Earth? The Earth itself, right? The Earth itself. So we're definitely immersed in a magnetic field of the Earth, and nothing's happened so far. So MRI is known as a non-invasive technique. There are a couple others also that are non-invasive that I'll show you at the end. But you can see here that a fully conscious brain is showing a lot of activity, right? Similar. Minimally conscious, much less activity. And a vegetative state, essentially no activity of the brain. But this is the cerebellum. This is cerebrum, the 2 hemispheres of the brain. If we were to do an MRI of the brain stem, right, below the medulla, what is your expectation? For a person who is in vegetative state, is the heart beating? A heart can be beating. How about, are they breathing? Vegetative state, they're also breathing, right? They're just in a long-term coma, if you will. And so the brain stem would be active, but not the brain. So that's why they're unconscious, but the vital organs are still functioning. Moving forward, traumatic brain injury or TBI. Typically, it's some kind of blow to the head. It's complex. It's a complex injury. It has a spectrum of symptoms, right? From mild to severe, from seeing cross-eyed to not being able to see at all, etc. There are many things that will be affected on the brain itself, and can lead to temporary or permanent disabilities, depending on how severe the blow is to the head. Just about any blow to the head will cause some hemorrhaging, okay? Even if it's a more gentle blow, but any blow on the head typically will cause some degree of hemorrhaging, but the brain is able to handle minor capillary breaks. But major ones is a different story. The site of Mayo Clinic, by the way, it's a very good site, and you can go to it whenever you hear of an injury or you get an injury or something like that. You want to know a little bit about the injury or the illness, whatever it is. Mayo Clinic has a very, very good website, all for free, can be explored. So TBI typically is subdivided into mild or severe, right, for different protocols of treatment. And the difference on average is about half an hour. If the person has not recovered from a TBI in half an hour, then it's considered severe. That's the average. Moving on to hypoxia, which is, okay, so OX is a reference to oxygen, or oxia, it's a reference to oxygen, right? Hypo is below or low, right? Low oxygen to the brain, or if it's anoxia, the AN negates the oxygen, so this would be anoxia, would be no oxygen to the brain. Low or no oxygen to the brain. Very, very serious condition. The typical case, of course, is drowning, but it could be someone choking and so forth, all right? Where there's first no oxygen or insufficient oxygen to the lungs, and then within a minute or two, that's going to be transmitted, that deficit is going to be transmitted to the brain. Here, just to illustrate the arteries, right? These are arteries to the head circulation. And the arteries are the ones that carry the arterial blood, is the one that carry the oxygen, right? And venous blood carries CO2 through the heart to the lungs, and that's on the body circulation. An easy way to remember the distinction between arteries and veins is that arteries go out of the heart. So if you think of the A in capital letters, A is like the tip of an arrow, right? So arteries go out of the heart, and veins is a V, and the V goes into the heart, right? So veins go into the heart, arteries go out, except on the pulmonary, well, that also counts for the pulmonary circulation. It's just that in the pulmonary, so in the systemic circulation, arteries are oxygenated blood or deoxygenated. Arteries carry oxygenated blood, right? And veins are carrying deoxygenated CO2 blood back to the heart to be pumped to the lungs. But then in the pulmonary circulation, that reverses, so that it will be the arteries going out. The pulmonary arteries are carrying CO2 blood because they're going to the lungs to get rid of the CO2. And then pulmonary veins are coming from the lungs to the heart, but they're carrying oxygenated blood, all right? So in the pulmonary, the thing reverses. Arteries are carrying CO2 blood and veins are carrying oxygen blood, but they're still, arteries and veins are still the same terminology when they're going out of the heart or into the heart. Let me move forward to seizures. Epileptic seizures, which are also known as a fit, all right, It's a neurological phenomenon, typically on the cortex of the brain. And as you can see here from the electroencephalogram, so this is an EEG, and it's measuring, what is it measuring? It's an electroencephalogram. It's measuring the electrical activity on the brain, okay? And how many leads are placed on the skull of this patient? We can actually count them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this patient has 10 leads, 10 little nodules placed on his or her head, and they're all going to a graph paper where you have the little, the tips of the needles reacting to the electrical activity and generating the graph or the gram, encephalogram, right? And this is what it looks like. As you can see, here would be the beginning, this is the end, right? At the beginning and at the end is normal, this is normal brain activity. But in the middle here, this high activity, that is the seizure itself. And you can see that essentially all of the leads, all of the 10 leads picked it up. So it's generalized. It's across the entire cortex of the brain, all right? It is obviously abnormal because it's not the normal sequence, the normal pattern. It's excessive, right? It could be abnormal in the opposite direction. Basically, a flat line would be abnormal, non-excessive, but this is the opposite. High activity is like a jolt of electrical flow going through the brain, right? And it's also synchronous in that it happens throughout all of the lobes of the brain. And generally, the person kind of faints, the eyes go up and so forth. They tend to tilt their head back and fall. So these are epileptic seizures. It's not really known exactly why it happens. Sometimes it happens to young people and then they grow out of it when they become old, or in some cases it remains chronic and they have to live with this all their lives, okay? But I can tell you from the bioethical perspective, it has been a challenge in the past because before the EEG was around, some people were buried thinking that they were dead. The people around them thought they were dead and they were not really dead. It happens that they had an epileptic seizure and it became so rigid and that people thought actually they were dead and they were buried, but they were not dead. And how do we know that? Because of a process called exhumation. I don't know if you've ever heard of exhumation. To exhume a body is to take that corpse out of the grave, right? Out of the tomb. For a number of reasons. It could be for forensics, if the body needs to be examined again or something like that. Or it could be, I know that in the Catholic Church is part of the process of beatification or canonization. If a person is being considered for sainthood in the Catholic process, part of that is to exhume the body to see if the body has corrupted or not. So what have they found when these corpses have been exhumed over the years and decades? In the past, right? Not always, but every now and then they would find on the inside of the coffin, sadly, they would find scratch marks, okay? And it's very, very tough because then one realizes that that person ended up asphyxiating to death. And to the point that these are actual designs that I found online. We're going back several centuries, but in the past, some sophisticated coffins had either bells or flags or whistles attached to them so that just in case the dead woke up, they could ring a bell or wiggle a flag, and so hopefully someone was looking at the flag at the moment, you know, when it was wiggling, so that they would quickly be unearthed, all right? But these are actual designs that are online. This is an actual photograph in a cemetery where you can see the bell to this day on the little cord there going in. All right, so there's some kind of a plaque. It's historical, of course. And why is it historical? Because now in the funeral homes, once a person has been declared dead officially, clinically by a medical doctor, then they're taken to the morgue, to the funeral home, funeral parlor, and then they're prepared. The cadaver now is prepared for the viewing or the funeral rites and so on and so forth, all right? And it may be several days. Therefore, one of the first things that the funeral home does today in the background is they drain the blood. And in draining the blood, they also put in the fluids, the preservatives they're gonna put into the tissue for some preservation, short-term preservation, all right? And so once they drain the blood, then there's a good assurance that person is definitely not alive anymore. But before they do that, they need the official declaration of death. That's why the declaration of death is so important. Because with that declaration of death, then the funeral home can proceed to draining the blood from a cadaver, all right? Which is, if you think about it, if that person is not really dead, then that's gonna kill him. Mm-hmm. Right, yes, of course. It's not done intentionally for sure, but that's why the declaration of death, yeah, the declaration of death is very, very important, legally, clinically, and bioethically, all right? So we have to be careful now, thanks be to God, with the EEG, the seizures on the fits can be monitored and distinguished from an actual death. All right, we're toward the tail end here. Syncope is, like I mentioned, just a fancy word for fainting. Typically, it's a temporary loss of consciousness. It's usually associated with low oxygen going to the head. For example, if we're lying down for a long period of time and get up very fast, sometimes, especially when it's older and the heartbeat is a little slower, the body, the circulation doesn't get enough circulation, enough blood to the brain right away, within seconds, and the person could be fainting, feel fainting. So that's a syncope, all right? Yeah, associated typically with a sudden drop of blood pressure. But it's temporary, generally it's inconsequential, and it doesn't usually lead to long-term unconsciousness. There are other seizures that are non-epileptic also. I just list them here for the sake of completion. And then finally, there's this locked-in syndrome, which is kind of the opposite. Here in locked-in syndrome, the person is actually conscious, but they cannot move their muscles or the skeleton, all right? So here the problem is somehow with the voluntary nervous system, they cannot move their body, except for maybe some winking of the eyes, the eyelids, and maybe some movement, I think vertical movement they can do of the eye, and that's about it. But the rest of the body, they can move it for whatever reason, and it's called locked in, but they are fully conscious. So they're really, it's technically it's not an unconscious state, but it looks like the person is unconscious because they can't move. Oh yeah, so here are some characteristics. The lower brain and brain stem are involved, but the cortex is functioning. Finally, just to compare the different states, here's locked-in syndrome, for example. You can see there's brain activity going on. Minimally conscious, less brain activity, but still some. Vegetative state, disorderly, bless you, is disordered activity. The coma, even less activity. These two, one difference between the coma and the vegetative state is that typically coma is short-term. Short-term maybe anywhere from 3 to 6 months, but beyond 6 months, if a person is still unconscious, then typically they are declared in a vegetative state. And then that can go on for years, all right? But coma is more shorter term, up to 6 months arbitrarily, between 3 to 6 months. But beyond that, beyond half a year, then as a convention, the person would be declared vegetative state. But the state of the mind is very similar for these two. Brain death, you can see that there is no coordinated activity going on at all right? It's disaggregated, some little part of a lobe may be firing up spontaneously, but there's no coordinated brain activity going on here at the cortex. And while I'm here, just introducing two other imaging techniques that are also non-invasive, all right? The positron emission tomography, or otherwise known as a PET scan. You may hear about a PET scan, right? It's a tomography. Tomography is to look at the contour of whatever organ, soft tissue, soft organs, and a computed tomography, a CT. So you hear about the PET scan, you hear about CT scan, you hear about MRIs. This is what they mean. Basically, they're non-invasive techniques to image soft tissue and even as the tissue is functioning. So they can establish a colorized scale to see what level of functionality is going on. And that can be real time because they're non-invasive. So this second part then, the main thrust here is to arrive at a diagnosis. A person who arrives, presents at the ER unconscious, you know, the doctors have to determine, have to come up with a diagnosis, because if there's no diagnosis, there's no prognosis. Okay, so what is the difference between these two words, which are keywords in medical practice? The diagnosis is the current state of the patient. What does the patient have? All right, what does the patient have? That's the current state of the patient. And then based on that, then there will be a protocol of recovery, of treatment or not, depending on what the patient has. Some diagnoses have no treatment, okay? Many do have a treatment. And so the prognosis is the hope of recovery, the hope of recovery. And the prognosis is based on the diagnosis. Depending how mild or severe the diagnosis is, well, the prognosis is going to be according to that, right? So it'll be a very good prognosis of essentially expectation of full recovery, all the way to abysmal, for example, which means that there's no hope of recovery for this particular patient. And that's the prognosis, all right? Okay, folks, that's all I have for today. Any questions, comments? All right, well, thank you once again for being here. Derek, I have your summaries here.
I just realized it's prognosis, it's like knowledge.
Oh, yes, that's right. Yeah, it's knowledge going forward, gnosis going forward. Exactly, knowledge going forward, right? Okay, thanks again. Let me stop the recording, stop the share. And we'll see you Monday.